Hemolytic disease of newborn, we have two conditions there. It may be due to RH incompatibility or due to ABO incompatibility. First of all, RH incompatibility. The RH incompatibility occur under the condition when RH negative mother has RH positive fetus. As the fetus is RH positive, then it means that its red blood cells contain Rh antigen. So when these Rh positive cells pass through the placenta into the maternal circulation, they cause the sensitization to form anti-D antibodies. The anti-D antibodies may form in other conditions like maybe due to trauma to placenta or due to previous blood transfusions. Then anti-D antibody pass through the placenta into the fetus circulation and coat Rh positive fetus cells, which are then destroyed by the reticuloendothelial system. Due to this destruction, it causes anemia. Anemia means reduction or reduced levels of hemoglobin, and jaundice. Anemia and jaundice are major clinical features of HDN disease. Anti-D antibodies are responsible for Rh incompatibility in most of the cases, although anti-C antibodies, anti-E antibodies, and anti-K antibodies also cause incompatibility in some other occasional cases. Then we will move to the ABO incompatibility. In ABO incompatibility, the mechanism of development of HDN will be same as that of Rh incompatibility. Except in this case, we have antibodies against ABO blood group, and these are the most frequent cause of HDN disease. The majority of the cases of ABO HDN are caused by immune IgG antibodies in blood group O mothers. As IgG antibodies can pass through the placenta easily, therefore they cause the HDN disease in newborns. Now we will differentiate between Rh and ABO incompatibility. Rh incompatibility may not found in first pregnancy, whereas ABO incompatibility may be found in the first pregnancy. Rh incompatibility affects the subsequent pregnancies, whereas ABO incompatibility doesn't affect subsequent pregnancies. Rh incompatibility has DAT positive test always, whereas ABO incompatibility has DAT negative or weakly positive. Rh incompatibility is more severe as compared to the ABO incompatibility and it requires therapy and treatment, whereas ABO incompatibility is mild as compared to Rh incompatibility and it most of the cases don't require treatment. In laboratory findings of Rh incompatibility, we have increased erythroblast and increased retics, whereas ABO incompatibility, we have spherocytosis, agglutination, erythroblastosis in peripheral film. In clinical features, we have first of all a general sign of anemia, pallor of mucous membrane and nail buds, which most commonly occur when hemoglobin levels are less than 90 gram per liter. Then we have tachycardia. Tachycardia means increased heart rate, edema, accumulation of fluid in the interstitial spaces and cavities. Hepatosplenomegaly means enlargement of liver and spleen. Kernicterus, it occurs when unconjugated bilirubin levels are increased and they exceed more than 250 micromole per liter. Then the bile pigments start to deposit in the basal ganglia, which causes the central nervous system damage. Then we have the mental deficiency and deafness and epilepsy. In laboratory finding, first of all, we have anemia. Anemia occurs when HB levels are less than 100 gram per liter. Reticulocytes counts are increased. Direct antiglobulin tests become positive because of the presence of sanitized RBCs with non-agglutinating antibodies. Serum bilirubin levels are increased as we have increased unconjugated bilirubin levels, which causes kernicterus, and erythroblast numbers are increased. In peripheral film, we have spherocytosis. Spherocyte numbers are increased, means, and we have autoagglutination, polychromasia, and erythroblastosis. For the diagnostic purposes, first of all, we will take the history and then the physical examination for the clinical features. Then we will go to the specific test. Like for the Rh incompatibility, we will done that test. As that test is always positive in Rh incompatibility, and then we will done R titer. For the ABO incompatibility, That test is performed and that test is negative or it may be weakly positive for ABO incompatibility. And then we will done ABO antibody screening and then heat illusion. Some blood tests which should be performed on the newborn includes the biochemistry test for the jaundice and the paraperfume to look for the morphology like for the spherocytes, for the erythroblasts, for the retics as their counts are increased in HDN. And that test should be performed as it is positive in most of the cases. Whereas the blood test which should be performed on mother include the indirect Coombs test and as it is positive most of the cases. That's all for today. If you have any question, you can ask in the comment section. And thank you.